We don't know most of the time what causes heavy periods in most women. It's a common experience, and many people would say that it's a normal experience that women have. It's just that some women have heavy periods than others. So in most cases, heavy periods are a normal part of the menstrual experience of women rather than being reflective of a disease. First of all, this is a very common problem. It affects a significant number of women and is then very limiting and debilitating for some women. And as such, it's a common problem in general practice and also an extremely common reason for referral to a gynaecologist. In terms of this study, before we started, we knew that there were plenty of usual treatments that we use that can reduce the amount of bleeding that women have. But what we didn't know was in what way treatments might be able to reduce the interference that heavy menstrual bleeding has on women's lives and on their quality of life. And that's what we were interested in, because often for the individual, it's not so much the amount of bleeding as the effect it has on their work or on their family or on their social relationships or indeed their emotional well-being. And we were interested in looking at those outcomes. There's a whole range of different treatments available for heavy periods. The commonest ones that we use in general practice are tablet-type treatments like mefenamic and tranexamic acid, and also the contraceptive pill and other different types of hormone, and indeed a long-acting hormone injection. Those would be the usual sorts of treatments that there are available. But more recently, people have proposed using a contraceptive coil called Mirena, which was designed to be used as a contraceptive. It's inserted in the womb and it releases a hormone called levonorgestrel, and that acts as a contraceptive. But it clearly had potential to also reduce people's bleeding. So we wanted to compare the use of this contraceptive coil to the other usual types of treatment that we use in general practice. This has been an excellent collaboration between people who work in general practice like myself and a whole number of gynaecologists, a very busy and diligent trial team, and many general practices and other NHS centres right across the Midlands and indeed beyond. And we wanted to try and answer our research question, which treatment is better, definitively in order to help women and doctors make informed decisions. Now, in order to do that, we had a stiff challenge because we needed to recruit around 600 women to this study. Women who were consulting their general practitioner about this problem. So it was sufficient for women to come to a GP and say, look, I've got this problem, and to then agree to be randomly allocated to either using one of the usual treatments or using the contraceptive coil. We followed women over the next 2 years and asked them if these treatments were helping and how. And in a nutshell, both types of treatment, both the usual sorts of treatments and the contraceptive Mirena coil significantly improved women's quality of life. But those who had the Mirena coil improved significantly more over the 2-year period. And by improvement, I mean that women experienced much less interference in their lives. So they had much less practical difficulties, running to the toilet and so on. They had much less interference with their social lives, their family life, their relationships, their emotional well-being. They could go to work more easily. These were the sorts of improvements we saw. The other thing to say is that those women who got the coil actually tended to stick with it better. So more women still had the coil and still had it in 2 years later. They hadn't asked for it to be taken out, it was still suiting them, than were using the usual treatments. And so the really important messages are, first of all, that we found that these sorts of treatments are helpful, are effective, and we didn't know whether they made much difference to women's quality of life. We now do know that. But secondly, it helps us in making more informed decisions about what to choose, bearing in mind an individual woman's preference for a contraceptive coil being inserted or not. And perhaps the other thing that I think is also very important, which we didn't look at directly, is that we now need to make women more aware that there's a range of treatments available that can be helpful. We know that many women don't come forward for treatment for this problem, either because they're embarrassed or perhaps they don't know that there are treatments available that can help. And this study, it's a very big study, and it underlines that we can help women if they choose to consider some of these options. Perhaps finally, the other point as a general practitioner would be that we need to offer the option of the Mirena coil more often in our range of treatments that we have available for women. In our study, around a third of women did not persist with the coil. It didn't suit them. They had irregular bleeding that persisted for longer than might have been expected. Normally, one would expect some irregular bleeding with this coil for about 3 to 6 months. And for some women, it was possible to put up with that because in the longer term, their bleeding settled down. But for other women, that was not acceptable, and so people wanted it out. So that's probably the biggest problem. I suppose the other is that, you know, having a coil inserted is simply not for everybody. It's sometimes not suitable medically for some people. If they have fibroids, for example, it may not be possible. Or if they've had pelvic inflammatory disease. For other women, it's simply a case of, well, it's just not for me. I'd much rather have some other form of treatment than have to go through a relatively straightforward procedure, but nevertheless a procedure to have a coil inserted.